Good morning, everyone joining today to the virtual series. For those of you that don't know me, my name is Adrienne Luckenbacher, and I'm your moderator for today. And you're joining medication-assisted treatment for opioid disorder with Dr. Janis Romanik today. So we want to welcome everyone again to our very last week of the opioid virtual series that has been provided by St. Clair County Community Mental Health in partnership with the Community Services Coordinating Body. This webinar that we've had all September, which has been National Recovery Month, has been made possible by a grant by SAMHSA, the Substance Abuse and Mental Health Services Administration. As always, when we go ahead to do the virtual series, we're going to do some housekeeping information. Please make sure that if you have questions, comments, if you want to share any resources at all, feel free to use the chat box. That will be checked by the monitor and the moderator, and we'll be able to forward questions to Dr. Romanik, resources, any kind of troubleshooting and things like that. So please use the chat feature at the bottom of your screen. If time allows, like the other virtual series, we're going to go ahead and answer questions if we do have time at the end with Dr. Romanik. We're going to do some housekeeping about different things, including continuing education credit. So as many of you know, CEs are provided today's presentation for those that registered or pre-registered at our website for the day. A couple of things to remember: you must be logged on for the entire duration of the webinar to get credits for CEs. If you lose connection for any reason, go ahead and log back in. You should be fine because we're able to keep track of that. CEs and credits will be provided for folks that complete the short quiz and the survey at the end, and that needs to be done within 7 days of the broadcast. The series today has an in and out code. The participants will need that in order to complete the quiz. Today's in code is Monday, all caps, M-O-N-D-A-Y, Monday. Also, to remind everyone, this is being recorded. However, continuing education credits are not eligible for those that view this on Facebook Live or look at a recording afterwards. It's only eligible for the live. So with that, we're going to go ahead and move into our presenter today. Dr. Janis Romanik is an established physician in the field of addiction medicine with 15 years of experience. She's board certified in both family medicine and addiction medicine. She's currently the medical director of Sacred Heart Rehabilitation Center. Dr. Romanik is an advocate of medication-assisted treatment programs and works to educate those through direct didactic sessions on both the benefits of medication-assisted treatment for opioid disorder and the stigma that's surrounding it. And with that, we would like to say good morning to Dr. Romanik and go ahead and let her start. Good morning, Dr. Romanik. Hi, folks. One moment. We're going to go ahead and have Dr. Romanik unmuted, please. Just 1 second.
Okay, can you hear me now?
I can. We can.
Okay.
Thank you so much.
So Sacred Heart, yes, I'm from Sacred Heart Rehabilitation Center. And today I'm going to be speaking on medication-assisted treatment. So I have no disclosures of interest or disclosures relevant to the content of this presentation. I do need to fix my screen one more time, and I do apologize. Okay, so the objectives for this course, I want to discuss medication-assisted treatment options. So that includes methadone, buprenorphine, and naltrexone for opioid use disorder. Describe the process to select the most appropriate treatments for patients, and it's going to be based on their severity of their opioid use disorder and different patient factors that fall into that. Discuss medication induction, stabilization, maintenance, and discontinuation when appropriate. And also the barriers to access and utilization of medication-assisted treatment with a focus surrounding on the stigma that individuals face when they are on medication-assisted treatment. So for medication-assisted treatment for opioid use disorder, there's 3 different medications. There is methadone, which is a full agonist, meaning you can kind of see by the chart that it binds to all, it kind of creates a whole activation. Buprenorphine, which is a partial, and naltrexone, which is an antagonist or a blocker. So even though I discussed the medications and that's my focus today, I want you to know that I also know that you've spent the whole month talking about therapy also. So therapy is extremely important. I don't really talk about it too much because I focus on the medication portion, but studies of cognitive behavioral therapy versus medication-assisted treatment versus the combination have shown the best outcomes when they are combined. So I do encourage that we combine therapy with medication-assisted treatment. Individuals who would be applicable for non-medication-based treatments, those typically are lower levels of use with a shorter duration of use. So, and not everyone will be on medication, but some people will. And the people that are most benefit from this are going to be the ones that I'm going to talk about later during treatment selection. So starting with methadone, methadone's an opioid mu agonist. What does that mean? Methadone is an opioid and it binds to the opioid receptor, the mu one. There's 3 of them. And the mu one's the most common one. It suppresses opioid withdrawal for 24 to 36 hours, and it does not cause sedation or intoxication once you're stable on it, if you're taking it the correct way. Typically during induction, you can have some sedation because they're getting used to it, but usually you do not once you're stable on it. The goal of methadone is to block withdrawal symptoms, cravings, and the reinforcing effects of opioids. So once methadone's bound, if they were to use heroin, they don't typically get too much reinforcement from that. It is a Schedule II. It comes in a liquid formulation and a diskette. In the methadone programs or in the OTPs, the opioid treatment programs, we do use liquid. It's a 10 milligram per milliliter liquid that we do use. It requires about 3 to 6 months to achieve stability in the medication, and I'll go over why that is. And the goal is to correct any biological abnormalities that opiate-dependent individuals are faced with. One thing to keep in mind is there's no evidence of any harm with long-term use. So a lot of people will come in and say, what causes my teeth to rot and they're falling out now? Methadone doesn't really cause that. There is some small amount of what we say osteoclastic and osteoblastic, which is what kind of builds up and breaks down bone. There is a turnover on that, but you get that with any opioid. It's not increased with methadone. So I don't want anyone to think that, you know, you'll have teeth rot, because that's one of the things we hear a lot. A lot of times what happens is when someone starts on any medication-assisted treatment, regardless of which one, they haven't been taking care of themselves as well as they should have if they've been using heroin or Norco. So they haven't been to the dentist, they haven't been to the doctor, and now all of a sudden they go to the dentist and they tell them they have 3 or 4 cavities. Well, now they blame it on the methadone, even though they've been on it only for 2 weeks. It should not cause that. So a lot of times they find things that were wrong with them that they were ignoring during their use when they were using heavily. So how do we distribute methadone out of an opioid treatment program? So methadone has to be distributed for medication-assisted treatment through a licensed narcotic treatment program registered by the state, an opioid treatment program. So within the clinic, it requires a physician to manage the dosage, a nurse to dispense it, yet again, dispensed as liquid. There are set hours that we do dispensing. So for example, it's 6 a.m. typically till 1 p.m. There's initial attendance to the methadone program. Everyone comes daily. So one thing to keep in mind is when someone starts at a program, they're coming in every single day. It's extremely heavily regulated. We get to see their faces every day. That's important because if they're struggling or they're having concerns, a physician's on site to answer the questions. The nurses can answer some of the questions. Also, it decreases on diversion. So that's a really, really important factor because we want people to be sober and stable before we give them a large quantity or take homes for medication. And it's kind of like a one-stop shop. So on site, not only do they have initial attendance, not only do they have a doctor and a nurse, but they also have counseling and psychological services, peer services on site. Everything is there for them. We do periodic toxicology screens of the urine. So it's mandated that at the beginning, we do it once a week. And then as they become more stable, it decreases to twice a month. And then we go to once a month as they become more stable. Not just on the methadone, but more stable in their recovery, and they're doing better. So outside of an opioid treatment program, physicians can prescribe methadone, and there's only 2 reasons why they can do that. One, if they're hospitalized, if they're opiate dependent and hospitalized, they get verification from the opiate treatment program, and then they can go ahead and dispense it while they're in the hospital. The other reason is pain relief. That's prescribed as a prescription. So they walk out the door with a prescription, and it is in a tablet or diskette form. One thing to keep in mind is we're so highly regulated that if you look at the studies, only 4% of methadone that's dispensed out of an opioid treatment program or an OTP is diverted. So when you hear individuals who are taking methadone on the street, or they are getting it from a friend, typically, because we really don't give a huge quantity of take-homes, especially at the beginning, they're getting it from a prescription or pain relief from a friend. Now, if someone's getting methadone from another doctor, we don't allow that. We do coordination of cares for every physician. We run maps. All those things are important. So how do we dose methadone? Usually we start anywhere from 20 to 30 milligrams. And the goal of this is we start low and we go slow. Adjustments typically are made every 5 to 10 milligrams every 3 to 7 days. The half-life of methadone is 24 to 36 hours. So we do the daily dosing. You don't have to dose twice a day. The exception is pregnancy. With pregnancy, they metabolize more rapidly. So they might, during the end of 2nd and 3rd trimester, we might do something called split dosing, where they get part in the morning and part in the evening. But that would be the exception to the rule. Average dose is between 80 and 120 milligrams. Depending on the individual's metabolism, it could be 80 to 150 milligrams. It's metabolized within the liver through the cytochrome P450. That's important because if any other medications they're taking are metabolized through this specific pathway, it can cause increased levels or decreased levels of methadone within the system. So for example, if someone went to a family doctor and they had been stable on their methadone for a really long time, they went in and said they had a urinary tract infection, and that individual placed them on Cipro. Cipro causes increased levels of methadone because it goes through that the metabolism. It causes the methadone levels or the plasma levels to increase. So if someone was stable for a very long period of time, went into their physician with a UTI and got Cipro, and all of a sudden they're acting sedated, it's not necessarily because of relapse. It's not necessarily because they're taking too much. It might be because they're prescribed another medication. So that's why taking a good history and watching them is very, very important. So what do we do the lab work wise? The state and federal government requires us to do a CBC, which is a blood count, a CMP, which includes liver, kidneys, electrolytes, a hepatitis B panel, RPR, which is for syphilis, urinalysis, and a TB test at admission, which we also do yearly TB testing because they are higher risk. We recommend, now it's not mandated by the government, but we do also recommend and do STI testing. So we look for things such as hepatitis C, because that's more common than hepatitis B, especially because of the immunization for hepatitis B. We look for HIV. We look for any of the STIs that might come up that are more common with individuals who are intravenous drug users or are using heroin. So why is it important to start low and go slow? Why are there regulations? So the regulations from the federal government say the most or the maximum dosage you can give on the first day of treatment is 30 to 40 milligrams. You can only give 30 milligrams, and if you want to give an extra 10 milligrams to get to 40 on that day, you will have to reassess them in 3 to 4 hours. Methadone peaks usually between hours 3 and 4. So in order to do that, you'd have to give them their medication, have them come back in 3 to 4 hours and do an assessment to make sure there's no oversedation. It's very rarely that we have to do that. It's more on the inpatient basis that we do that because we have eyes on them all the time. But you don't want to go over 30 to 40 on the first day tops. But typically we start 20 to 30. And our dosage that we start on, it does depend on the usage. So if someone's using heavily, for example, they're using large quantities of heroin, 1 to 2 grams, that might be someone who might need a little bit more, like 30. But if you have someone coming in who is prescribed hydrocodone, whether it's Norco or maybe Tylenol with codeine, some type of opiate that they're addicted to, that might be a reason to start them at 20 milligrams. One thing that patients have a hard time realizing is that the first dose, and really the first 6 weeks or so, they're really not going to feel great. So what I tell them is, you're not going to go run a marathon, but you are still going to be able to function, meaning go to the grocery store and do those things. So they're not going to feel where they should feel at their normal dose. Now, why can't we start them at, let's say we just take a random guess and say you're going to be at 80 milligrams. Why can we not start them at 80 milligrams? So methadone is unique in that it's slow and steady. So as you go up, because it takes time to build up in the bloodstream and build your plasma levels, you have to go slow. So this chart shows that on day 0, so the first day of dosing, let's say, for example, you give them 30 milligrams. It shows that it kind of goes up, it peaks in 3 hours and comes back down, but it stays up there. Now the next day, on day, you give them another 30 milligrams. Yet again, you're going to get that peak in 3 hours, but it continues to increase. And it will increase for about 3-4 days until it stabilizes. So 30 milligrams on day 1 might not look like what 30 milligrams on day 3 or 4 look like. So you want to make sure that you don't increase your dose too fast. So if you were to start them at 80, even though they're okay on day 0, 1, 2, by the 3rd day, they're extremely oversedated and it could cause overdose. And that's part of the reason that methadone is so highly regulated and there are so many rules surrounding it in an opioid treatment program, is because if you start too soon during the induction phase, you can overdose them if you try to start them on what you think they might be on. So starting at a lower dose and then waiting so many days is quite important. And that's also the reason why we only do dose increases, between days 3 and 7. Usually we typically do 4 and 7 just to make sure. So if someone's at 80 milligrams and we just did that on, say, a Monday, we won't consider reevaluation or increase till Thursday because we want to see what those plasma levels do. So we want a steady state. So what are the pros and cons of methadone? A lot. The pros are, you're coming into one center, you've got everything at the same place. You've got their medication there, you've got therapy, you've got the physician, you've got the nurse. It's a one-stop shop. We get to lay eyes on them at the beginning every day. So there's more frequent monitoring. When individuals are started on methadone, it decreases their risk of intravenous drug-associated diseases from injecting. It decreases criminal activity and overdose risk. And we see improved family stability, improved pregnancy outcomes. It's got a long track record of efficacy and safety. It's been prescribed since the 60s, 70s. We see a reduction in other drug use when people are on methadone. It allows the methadone-maintained individual to function normally at work and in the home. So even though at the beginning they might feel a little bit of sedation during the induction period, once they are stabilized at a dose that's appropriate for them, even though that can take 6 weeks to 3 months, give or take, they have no sedation from it as long as they're taking it as prescribed and they're not taking it with any other sedating medications. So other sedating medications, you know, include benzodiazepines, barbiturates, some type of sedative hypnotic. We, in our clinic, don't allow methadone with a benzodiazepine. We frown on it. We don't recommend it. The combination of methadone with a benzodiazepine, whether it's Xanax, Valium, any of those, Klonopin, can increase the risk of overdose and death. Being on methadone reduces relapse to illicit substances, and there's no evidence of harm with long-term use. Some cons for methadone. There's a restriction in time and place. So the opioid treatment program, or the OTP, has set dosing hours, meaning those individuals have to be in during the hours that that clinic is open. And each clinic is different. So for example, one of the clinics that we have in Madison Heights for Sacred Heart, we're open 5:30 to 2. But our smaller program might be only open 4 hours. So from 6 to 9 or 5 to 9. We have another program that's only open 6 a.m. to 1 p.m. So you have to present at that time. So if you present after that time, so if the clinic closes at 2 and you present at 4, nursing staff won't be there to give you your medication. So there is a restriction in the time and the place that you can get the medication. There's a huge stigma, which I'm going to talk about at length regarding methadone. And if you do give doses higher than normal and then needed, you're going to see euphoria and overdose. So that's very, very dangerous. Side effects of methadone: constipation, just like with any opioid, and these are actually similar to all opioids. You get constipation. So if you're on methadone, you get constipation. If you're on Norco, you get constipation. If you're on buprenorphine, you get constipation. All opioids cause constipation. You can see an increased appetite or weight gain. Individuals will complain of excess sweating, so they'll come in saying they're having a lot of sweating. Sometimes they confuse this with withdrawal symptoms. So as they're increasing their dose, they'll come in and say, I'm sick, I don't feel good, and I'm sweating through shirts. That's normal. And typically the higher you go in your methadone dose, the more sweating you do see, just like any other opioid. You do have some drowsiness during the stabilization, induction stabilization phase, so you do have to watch for that. Hypogonadism, so for our males, what you'll see is individuals will have lower testosterone, and that's the same with any opioid, whether it's buprenorphine, Norco, they all cause decreased testosterone levels. So you have hypogonadism, maybe a decreased sex drive. One thing you do see with methadone, which is really important to keep in mind, is something called a QT prolongation or torsades. So when individuals are continuing to increase, and what QT prolongation is when someone has an EKG, we look at different numbers. And when the QT interval on that EKG gets longer, it can throw you into a rhythm called torsades. And we notice this on higher doses, so doses greater than 120 milligrams. What we've done in our clinic, and not every clinic does this, is that once they hit 150 milligrams, we require an EKG. If we will not go up on the dosage without that EKG. If their QT is prolonged, we will decrease their dose. We want them safe and healthy. Okay, so the next medication, buprenorphine. So this is a partial opioid agonist, meaning it has somewhat less opioid activity, binds to the same receptor, the mu receptor, or the main opioid receptor in the body. It can be dosed out of an office. So this is unique to buprenorphine. So buprenorphine, the trade names for this is Suboxone, Subutex, Zubsolv. Now there's an injectable called Sublocade. There's a buccal one where you can kind of put it into your mouth and it's, works like that. So there's a couple different ones out there, but they're all buprenorphine products. One thing you'll notice when I say buprenorphine, most of the medications have naloxone in them. So for example, Suboxone, Zubsolv, They are buprenorphine / naloxone. So what is naloxone? It's Narcan. Why do we put that in there? One of the most important reasons we put that in there is to decrease diversion. So if someone was to try to crush or inject their Suboxone, the naloxone would take over. So when individuals take Suboxone orally, or Zubsolv or any of the other trade names, when they take it orally, it's mainly absorbed through the two large veins under the tongue, because it does go under the tongue. When individuals attempt to go ahead and inject buprenorphine or Suboxone, the naloxone takes over. So if you inject it, the naloxone takes over, so you're initially Narcaning yourself. So that's the purpose, is to decrease diversion as far as how we take the medication. The exception for the trade names is Subutex. Subutex is buprenorphine only. I do not prescribe Subutex. So there was at the beginning when we began prescribing buprenorphine, we would write Subutex. So without because it doesn't have the naloxone for our pregnant patients, we don't do that anymore. ASAM came out, came out with some new recommendations, and so did SAMHSA. And it's in one of their pamphlets that most people do write Suboxone, and there's no increased risk. So the thought process initially was the less things we're giving pregnant individuals, the better. But being that naloxone is poorly absorbed when taken under the tongue, almost no naloxone or Narcan will be absorbed through that tongue, through underneath the tongue, through the sublingual. So right now we write Suboxone or Zubsolv, their normal medication. We do not write Subutex. Subutex does have a higher street value because it doesn't have the naloxone in it, so individuals can inject it. So we do not prescribe it typically. So what's important about buprenorphine or as a product? Why did we come out with this? So they initially were using buprenorphine as a pain management drug. But what they found, it was really poor as far as pain management. It didn't work very well. But they found individuals they gave it to for pain management used less, who were also addicted to other medications used less of their illicit substances. So then it came around that it was a good medication for opiate use disorder. So they created this. The nice thing about it, it can be dosed out of an office setting. So you can go to your family doc to get it. You can go to an addiction medicine doctor outside of opiate treatment program. So it's really a positive thing. So you don't need to go to a specialized clinic. The individuals prescribing it, though, within those clinics need to have a Data 2000 waiver with their X number assigned to them. So it's an 8-hour training course, which doesn't sound like a lot, but it does a good job for physicians. And it's a 24-hour training course for physician's assistants in order to apply and get your X designation and add it to your DEA license, meaning you can prescribe. They also do start off slow. For the first year, you can prescribe to 30 patients. The second year, you can increase it to 100. You do have the ability to increase it, or 30 to 100. Yeah, you do have the ability to increase it to more than that, over 200, but you have to also have some type of therapy on board, and you have to attest to that every year with the federal government, with the DEA. They send you a pamphlet. So if you are a family doc doing this medication, then you would need to go ahead and you wanted to go over that 100 limit, then you would need to contract somehow or have a MOU, like a meaning of understanding that you could send to this therapist so that you can keep those records on site. So the bonus is, because I'm out of an opiate treatment program, we have therapy right on site for that. Individuals also don't have to come in as often. So usually with buprenorphine, you start on day 1. I give them like a 3-day supply to start. and then increase their supply as they're doing better, along with urine drug screens and running MAPs. So monitoring compliance. And this is with methadone, this is naltrexone or Vivitrol, and this is with buprenorphine. You want a treatment contract. You want them to know what they're allowed to do and what they're not, and that they're contracting with you to be in treatment with you. What you don't want to see is individuals getting Suboxone from a doctor while they're getting methadone from a clinic. So it's to counteract that. It requires frequent visits at the beginning, which decrease as they do better. So one thing we do to decrease diversion, whether it's buprenorphine products, I'm going to say Suboxone because it's most people know that, whether it's Suboxone or methadone, is we do for buprenorphine, we do pill. It used to be in a pill form. It's pill form, film form. There's multiple forms now, but we do pill counts or film counts. And with methadone, we do bottle counts. So if you've earned the right on methadone to have an increased supply because you've been in treatment well and you've been doing well, you have to, if we call you, bring in all your bottles so we can check them, the ones that are left, and make sure they're sealed and you're not diverting them. Same thing with Suboxone. We do counts where we call them in randomly, usually once or twice a year at least, and have them do a count. On all of these, whether it's methadone with all the medication-assisted treatments, we do urine drug screens periodically. And we also recommend for everybody to do MAPs. If you're not registered, you should be, because I think you need to be regardless of what medication you're prescribing, even outside of medication-assisted treatment. If you're prescribing an opioid in general in your family practice or in your normal practice, you need to register, and you need to run MAPs every time you prescribe it. So that's our prescription monitoring program, and it tells you where also they're getting medications. So if patient X is getting buprenorphine or Suboxone from you, but is also getting Norco from another doctor, it will show you that. So that way you can get a coordination of care. We require anyone who is on any of our medications to have coordination of cares with all their prescribers. It's a safety issue. Suboxone prescribed or buprenorphine products prescribed do show up on MAPs. One thing that's really important to remember regarding methadone is methadone, unless it's prescribed for pain management, which will show up on MAPs because it's filled at a pharmacy, due to 42 CFR, we do not put individuals' information who are in clinics getting methadone onto the MAPs. So they could come in and see you and they could say they're not on anything because you're not going to see out of an OTP that they're getting methadone. Now, most recently, within the past 6 months, SAMHSA and the federal government put out an issue that you can enter that information with patient consent. A lot of times patients don't want to consent to that. So it's kind of a tricky thing. But with buprenorphine, unless you're dispensing directly out of your opioid treatment program, you're writing a prescription for them and you're sending it in, and that will show up on MAPs. Sublocade is an injectable form of Suboxone or injectable form of buprenorphine, and it's once a month, which is really nice. And that is buprenorphine only. It's done sub-Q, it's done in the abdomen. I wish more people would do it, but some people just don't want to. And then the nice thing is you don't have to really worry about diversion with it because they get their once a month shot and they can't divert that. So the good thing about buprenorphine is that there's fewer significant drug-drug interactions, and it's due to its low affinity for the 3A4 isoenzyme. So it's metabolized also by the cytochrome P450 system, the same as methadone. But because of its affinity for the specific isoenzyme that it binds to within that system, you have fewer drug interactions. So you can prescribe them Cipro and see very little interactions, which allows us to dose it a little bit differently. Yet again, just like methadone, we don't really want individuals on benzodiazepines with buprenorphine. So the times that you see overdoses usually and individuals on Suboxone, you'll see a benzodiazepine or some other sedative substance. Alcohol is a huge one for both of them. So no alcohol, no benzos. Anything sedative will cause an overdose or could cause an overdose. Buprenorphine alone, and I'll go into this at great length, will not cause an overdose by itself. But if they're taking a sedative hypnotic like a benzodiazepine, or if they're drinking alcohol with it, it will cause an overdose, or it can. So anyone who is using benzodiazepines and you can't get them to discontinue, any type of polysubstance abuse, individuals drinking alcohol, those are ones you might want to consider, and I'll go into this more treatment selection, referring them to an opiate treatment program or for methadone, because that way they have daily oversight, meaning they're coming in every day, which buprenorphine typically they do not. For buprenorphine, impairment is not clinically significant. So yet again, they can work, they can do everything that they would normally do without any problems. So side effects for this, they're similar: constipation, some nausea, some vomiting, some hypogonadism with it, because anytime you're on an opiate long-term, that happens. So I want to talk about how you start it. So induction. So something that's different than methadone. If someone used heroin an hour before and you wanted to start methadone, you could. That's not the same with buprenorphine or Suboxone. You can get something called a precipitated withdrawal. So the reason being is buprenorphine products have a high affinity for the mu receptor or the opioid receptor. So it will displace any other full agonist opioid. So heroin, morphine, oxycodone, methadone, anything that's a full agonist. So what does that mean when I say affinity? It means, think about it as a hug. So methadone or let's say you're using heroin, and heroin will it's kind of like a hug where you kind of pat it on the back, versus buprenorphine's a bear hug. It sticks there, it's there very strongly. So because the other ones have a lower affinity, meaning they don't bind as strongly to that receptor, if you were to give a Suboxone or buprenorphine product too soon, then you'll cause them to be sick. They go into withdrawal. It's called a precipitated withdrawal. So what you need to do is wait a certain period of time. They need to be in moderate withdrawal in order to start the medication. So if someone used heroin, I typically like them to wait at least 12 hours after the heroin use. Because a lot of the heroin, it might not actually be heroin, which we see is it's fentanyl, it's other things. Usually I try and push those patients to a 24-hour time span before we start the buprenorphine, so they don't have a precipitated withdrawal. And when I do start them, I start them at a lower dose. So typically most individuals are on anywhere between 8 to 16 milligrams. So I start them at 2 milligrams, or I have them break their tablet or cut their film and take that 2 milligrams first. Now that's off label. You're not supposed to cut the films, but I've been doing it for years without a problem, and I'm going to continue because it's cheaper for the patient and it's easier. So we have them take 2 milligrams and reassess in 2 hours. If they're doing okay, then they can take another 4 milligrams for 6 and take another 2 milligrams later. So the max dose that I like individuals on the first day is 8 milligrams for the first day on Suboxone. After that, they can increase on the next day if they're having withdrawal symptoms to 16 milligrams. So on and so forth. So you can actually get them to a stable dose much more rapidly than you can methadone. So once attached, other full agonists cannot bind to the receptor. So this is that bear hug. So once buprenorphine does kick off the short-acting opiate, the one that has less affinity or does not as strongly bind to that receptor, and buprenorphine's bind, it's like a bear hug. It's impossible to get it off. You have to really work at it to get it off. This is important. If a patient tries to use heroin while on buprenorphine, they're not going to have that euphoria, not just heroin, any type of opiate. So buprenorphine is bear hugging that so strongly that if someone was to use heroin, you don't get that euphoria with it. You can't keep that. So the heroin pretty much is a wash. It, you know, goes through the system without any effects. So buprenorphine also, and this is unique to this, has a ceiling effect, meaning giving more doesn't change the amount it can bind to the receptors or the amount of action it has on it. So opioid receptor availability decreases with increasing doses of buprenorphine. The opioid effects increase with each dose until at moderate doses they level off, even with further dose increases. So there's no maintenance benefits above 32 milligrams. Most people do not need 32 milligrams, and I'm going to show you why. So when looking at the brain scans, the top one where you see all those, that green, those are your opioid receptors. That's where the buprenorphine can bind, or the Suboxone. So buprenorphine 2 milligrams is the second one down. You see less green. So when you give someone 2 milligrams of buprenorphine, the less green means those are the receptors they're binding to. It decreases significantly. Then you go to 16 milligrams, there's almost no green. And then 32, there's almost no green also. There's not a huge difference between those numbers too. So if you look at the receptor occupancy, meaning how many receptors are bound when someone is on buprenorphine or Suboxone, at 2 milligrams, you have 27 to 47% of the receptors bound. At 16 milligrams, you have 85 to 92% of those receptors bound. And then at 32 milligrams, you have 94 to 98% of the receptors bound. So the higher you go up on that dose, you really don't get any benefit from it because there's no receptors for it to bind to. We typically max out around 16 milligrams at our center. Now, I do have, and I can tell you the quantity of people. We have 4 people on 32 milligrams, or 24 milligrams, I'm sorry. Most people were transferred. They were transferred in. Do they need that much? They say they do. We maintain them on them, but usually we do not go above 16 milligrams because really, is there a big difference between 92%, 94%? No. So that's where I feel like therapy needs to take a huge component. That's that seeking, that's I need more. If one is good, 2 is better. So therapy and figuring out their triggers is an important part of this. So that should take up that portion of it. This is also the reason why it's very difficult to overdose when you're on a buprenorphine product alone. So unlike the other one, methadone, the increasing doses of methadone, you can overdose as you go up, and the higher you go, if you go too high, you can see that euphoria. But with buprenorphine, with that ceiling effect, the more you take, you're not going to see much. I once had someone who came in inpatient, and they had taken, I think, 8 strips. And I thought, what a waste, jokingly. Like, you didn't need to take that many. There's only so many places it can bind. You can't really overdose on buprenorphine alone. And that's why it can be written in an outpatient setting by a family doc or someone that's closer to you, addiction medicine doc, outside of that opioid treatment program. So that's why the Data 2000 came into effect, and then people could learn how to prescribe and start giving it. Now, the exception to the rule is when you see overdoses sometimes, and they are on Suboxone, buprenorphine products, usually there's a benzodiazepine on board, they were drinking, there's alcohol, so there's a sedative, some type of sedative hypnotic with it. So what about misuse? So in 2018, I don't have the 2019 data, it comes out this month. It might have come out probably in the last week if I have not checked, but they come out in September with the year before. But 2018, just like 2017, the most misused opioid was buprenorphine at 28%, compared to hydrocodone, oxycodone, regular codone, tramadol, all of those. This was the most misused. The thing to remember is it's not misused, and this is the unique thing, it's not misused because people want to get high on it or feel euphoric effects, it's misused because people don't have access to treatment. So when they don't, they will use someone else's medication in order to mitigate any withdrawal symptoms. So if for some reason they can't get heroin because heroin's much more expensive than a film of Suboxone, they will go ahead and buy one film of Suboxone, and that can last them a day or two. And then they can re-up and get their heroin after that because heroin's more expensive. The other reason people misuse it is there's individuals who will tell their families that they've been sober. Now Christmas comes along. Well, how do I pretend I'm sober and be, in front of my parents or my loved ones because I told them I had been sober for 3 months? They will buy a buprenorphine film or two, and they will take that instead. So unlike heroin, which wears off in 4 to 6 hours, buprenorphine lasts at 24 hours. So they only have to dose once a day, and then they feel okay and they look normal. They feel normal too. So individuals are misusing it for that reason. It's not because they're misusing it to get a euphoric effect. So does buprenorphine work? It does. So there's a study done in Sweden where they looked at 40 patients and with greater than 1 year of heroin addiction. They did not meet criteria for methadone, these patients. They put half of them on 16 milligrams of buprenorphine, and they put the other half on placebo. And they did the study for 12 months. Both groups received intensive psychosocial therapy, so cognitive behavioral groups weekly individual sessions, 3 weekly supervised journeys. And what the outcome was for 1 year retention and treatment, 75% of the buprenorphine patients still remained, but 0% of the placebo were there. Those remaining in treatment on the buprenorphine, 75% of them had negative urine drug screens for illicit substances. And in the control group, the placebo group, 4 of the 20 patients ended up dying. While there was no deaths in the buprenorphine group, or those who were prescribed buprenorphine. So what are some of the stigma surrounding it? People look at opiate use disorder as a moral weakness or a willful choice. They get questioned why they don't taper off of it. There's a separation of opiate use disorder treatment from the rest of healthcare, and people think of it as substituting one drug for another, along with the language that we use, and it can perpetuate the stigma. So chronic illness. I know Dr. Saeed went over the neurobiology last week for you guys on why it is a chronic illness and why it needs to be treated like a chronic illness. So it's not a moral weakness. It's not a willful choice. The brain changes. Your prefrontal cortex, your nucleus accumbens, all those change. You have less dopamine receptors while you're using. There's individuals with, they're genetically predisposed. It can be environmental. But many in the community believe that recovery depends solely on willpower to abstain from all opioids, and that includes methadone and buprenorphine. A lot of the residential services force the patients to taper off the medication as a condition of treatment. Counselors, not all, but some counselors will consider taking medication as a character weakness. There's a fear of being ostracized in mentioning that they're on medication in support groups. So specifically, Narcotics Anonymous typically frowns upon any type of medication-assisted treatment. So really, they came out with something called MARS, which is medication-assisted recovery, or an MA meeting. So they can go there and not feel stigmatized or be told they should be off that medication. Some NA chapters do exclude people taking methadone or buprenorphine from holding any leadership roles or even attending meetings. So why not taper off of it? So for methadone maintenance versus taper, this was a study that was done by Season 2000. It looked at methadone maintenance treatment versus 180-day psychosocial detox. So methadone maintenance individuals receive psychosocial services for 2 hours a week. The 180-day methadone detoxification group receives psychosocial services for 3 hours a week, 14 education sessions, 1 hour of a cocaine group, and the dose reduction began on day 120. So what we saw is increased treatment retention. So there was decreased heroin usage and HIV associated behavior. So if you look, the dotted line is those who were allowed to maintain on their methadone maintenance. So there was a huge quantity of individuals who were retained on that. The other one looks at those who were placed on methadone, but then had a quick 180-day detoxification from it. And if you look around day 180, when they start dropping the dose, people dropped out of the program. And the individuals on the 180-day detoxification actually received more psychosocial services. So you do see increased treatment retention with people on methadone maintenance. What about buprenorphine maintenance? They did a completion. There's a study done that they completed either a 14-week taper after 6 weeks of stabilization, and other ones were maintained on the medication. So in the taper, you had 11% of people remaining at the end, versus on the maintenance group, 66% of those participating were still there. For urine negative for those on those medications, the taper group, 35% had urine negatives, and the maintenance group, 53% were negative for any illicits within their urine. So tapering typically is less efficacious than ongoing maintenance in prescription opioid dependence. So it's done by Phelan in 2014. The max dose typically, or that they did go to, or that they maintained around, or the average was about 16 milligrams, which based on what we saw in the previous study, as far as receptor availability, about 16 milligrams is where you've blocked most of the receptors. So individuals in the group who are maintained do better. So individuals who do taper off, numerous studies showed that greater than 80% relapse rate over time when comparing those who did not taper. This is for methadone, but similar rates of relapse are now reported comparing buprenorphine maintenance tapering. There's a separation in individuals on medication, so that so there's a reluctance to disclose the medication to healthcare providers. So if someone goes in for treatment and they're doing very, very well, they've been sober for 2 to 3 years, and they're on Suboxone or methadone, the first question most providers ask are, why are you still taking it then? You're doing so well, why not discontinue it? And that's a fear that a lot of patients have, so they don't want to disclose that. Individuals who do disclose it notice a marked change in providers' attitude. They're concerned they're not going to get as high of quality of care. And there's typically a mismanagement and pain control. If they're in the ER or have surgery, they mismanage their pain. And part of it is most healthcare providers have a limited knowledge regarding medication-assisted treatment. Others attribute signs and symptoms of non-opioid disorders to methadone and buprenorphine. A lot of times when they disclose it and they are suffering from something else, they'll say, well, it's probably from the methadone. Most of the time it's not. So they will tell them and kind of pawn it off to methadone or buprenorphine. So we miss treatment, mental health, physical health conditions, we attribute it to the methadone or buprenorphine if we have that stigma associated with it. Running out of time, but substitution. So are we substituting one drug for another? Because I hear that a lot. Opioid substitution treatment is a widely used term in Europe and Australia, and the terminology is really misleading. Methadone and buprenorphine are treatments for opioid use disorder, not a substitution. So, and I know Dr. Saeed went over physical dependence versus addiction, and there is a clear distinction between the two. Individuals on methadone and buprenorphine with negative urine drug screens and no other criteria for opioid use disorder are physically dependent but not addicted to the medication. So will they have withdrawal symptoms coming off of it? Yes. But they're not actually addicted to it. So addiction versus physical dependence. So if someone's addicted to something and you discontinue it, or someone's dependent on it and you discontinue it, they will have withdrawal symptoms, but that does not make them addicted to it. Addiction is all the activities and all the thoughts and behaviors surrounding it. So when you look at addiction, those individuals who are still addicted to something, they miss things. So for example, someone who's physically dependent, when they start those medications, they're able to go to family events. They're able to see their granddaughter's recital or their child's recital. They're attending all those. People who are physically dependent just have withdrawal symptoms. So the goal is that we want to maintain them because we want them to do well and be able to participate in their life again. So studies that evaluated cerebral phosphorus metabolites, so your creatinine phosphates, your phosphodiesterase, your phosphomonoesterase in opiate-dependent individuals. There was a study on it, and they showed that higher levels of creatinine phosphate showed higher metabolic rate and better cerebral perfusion, whereas higher levels of phosphodiesterase and phosphomonoesterase indicated higher membrane turnover and less stability. So they looked at 15 methadone maintained subjects, and they looked at 39 weeks versus 137 weeks. And what they saw is that nearly normal metabolic profiles in long-term methadone maintenance subjects suggest prolonged methadone maintenance treatment may be associated with improved neurochemistry. So treatment rather than substitution is a more accurate term. So when you look at these graphs, the 39-weeker is the one that's completely shaded. The 137-week person who's been maintained on methadone for 137 weeks has that cross-hatching, and control individual who is not addicted to anything and not on any medication is the white. So what you'll see is the goal is to get kind of closer to the normally maintained individual. So 39 weeks versus 137 weeks, you see the individuals who are maintained on methadone for 137 weeks come closer to someone who is normal and not maintained on anything, your control group. So it is a treatment, not a substitution. The language you use is important too. And I'm sure we all know, like urine drug screens, we use the word clean, dirty rather than positive, negative. That perpetuates the stigma. We talk about tapering off and decreasing the dose. We use that term detoxification, like we're getting rid of all these toxins, but really we're just decreasing the dosage. Just like hypertension medication, you're going to decrease your dosage. You're not detoxifying from your lisinopril. Therapy that does not involve medication, we call it drug-free. So there's an implication that taking this medication, you can't be in recovery, and that total abstinence is required for recovery. So the language that we use about opiate use disorder perpetuates that stigma. And does it work? So studies in Baltimore, and this was one of the longest running studies from 1995 to 2009, showed increased access to opiate agonist treatment was associated with a reduction in overdose deaths. So as Baltimore increased the quantity of medication-assisted treatment programs that people had access to, that big red line, you saw a decrease in those heroin overdose deaths. Naltrexone is an opioid antagonist, so it's a little bit different. It binds and it blocks. So it works at the midbrain on dopamine release within the ventral tegmental area, nucleus accumbens, and it decreases rewarding properties and decreases usage. It can be used for both opioid dependence and alcohol dependence. The most difficult part of starting someone on naltrexone is they have to be opioid free, and depending on the opioid will depend on how long you have to be opioid free, but on average 7 to 10 days. So they have to be completely through detoxification prior to initiation. So sometimes it's difficult for people who are opioid dependent to start on this medication because they will have to stop using heroin for those 5 to 7 days. Or that's really, really difficult. There's no physical dependence on naltrexone. Naltrexone is Vivitrol. Treatment retention rates for naltrexone typically is 20 to 30% over a 6-month period. The patient population that does well on that include healthcare professionals, business executives, individuals on probation or parole. They are very motivated and they really do well on that. So people who have more of a support system do well on this. So to decide who gets treated with what, you have to individualize treatment. So there's a huge overlap on it. You know, one is not necessarily better than the other. Things you have to look at. If you want to put them on methadone, do they have access to a methadone treatment center? The rural and urban areas do not. If they want buprenorphine, do they have access to a buprenorphine waiver provider? If they want naltrexone, are they able to go through detoxification prior? And naltrexone or Vivitrol doesn't require any special license. And there's something to look at too is patient personal bias. Some people are more likely to want one over the other, and sometimes that does come into effect. Also, polysubstance abuse, psych, mental health illness, pregnancy, those will also kind of lead you on to what you need to place someone on. So individuals on methadone, if they've had failed attempts on abstinence, do they have access to a treatment center? Do they have concurrent chronic pain? Those are individuals who want on methadone. For buprenorphine, do they have access to a waiver physician, access to a counseling center? These individuals, you want them to have moderate level of social support. And these individuals, if you have concurrent chronic pain, you might want to think about methadone, but you could also just think about buprenorphine. You just have to dose it a little bit differently. Naltrexone, if they have no access to any methadone or buprenorphine, this might be an option. If they are able to abstain, that's great. Were they recently incarcerated, so they're off medication? Were they recently detoxified from an opiate agonist therapy? Big thing, do they have no upcoming surgical interventions because it's difficult for pain management when they don't? And do they have a history of compliance with treatment? So sorry I sped up at the end, but I know I'm out of time. So key points: addiction is a chronic brain disease, no different than any other chronic disorder. So you want to treat it like that. All treatments work for some patients, but not one treatment works for all patients. Substance use disorder typically has a poor prognosis, so it makes sense to apply all of these treatments. And treatment's most effective not only when you do work on the medication, but also when you include therapy. So when both psychosocial elements and neurobiology are considered and addressed.
All right, just getting back on. Thank you, Dr. Romanik, so much. And we appreciate all your information. It was a lot, but it was a lot of really valuable and interesting information, and we appreciate your time today. Thank you so much.